Welcome to this series of interviews with the giants of cardiac surgery. My name's Joel Dunning and we're here at the STS in San Diego with Professor Joe Coselli. You're Professor of Cardiothoracic Surgery at the Baylor College of Medicine and Chief of Adult Cardiac Surgery at the Texas Heart Institute. You were mentored by the pioneering aortic surgeon, Dr. Stanley Crawford, and you've performed more than 7,000 surgical repairs of the aorta and nearly 3,000 open repairs of the thoraco-abdominal aorta, which makes you the world's most experienced surgeon in this technique. It's an absolute privilege to have you here, and I thought for our audience, as me as a sort of just a general cardiac surgeon, I'd really love to hear from you your really tips about the type A aortic dissection. It really is the thing for me as a cardiac surgeon that, you know, that phone call gets my pulse going, and I'd really love to hear sort of your tips and hints. So maybe if we start right from the start, you know, I'm rung up by a peripheral hospital, you know, an hour away. They think they've got a dissection on a CT scan. You know, what's the first advice we should be giving to these people, and how quickly should we be bringing them to our own institution?
Yeah, Joel, it's good to be here. Good questions and a very, very good topic, acute dissection. It's something that everybody has to deal with, even in tertiary centers out into our peripheral centers. Recognition and proper diagnosis is always key, and you're absolutely right. They never fall into your lap on Monday morning at 9:30 in the morning. They're always seems to be at night on weekends and holidays. And I calculate, although it's off the cuff, we probably get 1 to 8 or 1 to 10 out of our own emergency room. Most of them are the phone call that you're talking about. You get patients in an emergency room somewhere. They've showed up. The emergency doctor, who's the first responder in this situation, goes through the needle in the haystack and fortunately identifies, for whatever reason, either the type of pain or the physical examination with some pulses not being quite right, etc. Generally makes the diagnosis in one of two ways, either a CT scan or a CTA, or an echocardiogram where the ascending aorta is looked at, much less commonly in an emergency situation in the form of an MRI. We consider all type A or DeBakey 1 aortic dissections, as a surgical emergency until proven otherwise. And so we take the diagnosis on face value from the institution. It's very important for them to send the actual studies with them, not just the patient, because it is that piece of information that you're really going to make and base all your decisions upon. And it would be unfortunate to have to get an individual to your hospital and have to repeat the CT scan, for instance, after it's already been done because it wasn't included in the transfer. We think that these individuals need to be, from a transportation standpoint, moved as quickly as possible. That can be a different scenario depending upon where you are. In our particular location and many in the United States, if it's a reasonably close facility, a simple ambulance can do fine. In other cases, extending further out, it might be a helicopter ride, and then getting a little further out from that, it might be a fixed wing. But we encourage them to get these patients to us as quickly as possible. We also ask them to address a few issues up front. If in the unfortunate situation that they've maybe have a mechanical aortic valve, atrial fibrillation, or for any other reason are taking Coumadin, we ask them to go ahead and start the reversal process. If it's going to be a delayed period of time before we can get them to our institution, we might even ask them to give them some FFP if the INR is quite high. Otherwise, we'll certainly ask them to give at least some vitamin K. The other thing involved with the transfer is at least a couple of other things. One is blood pressure management. We like to have these people transferred with adequate monitoring, adequate IVs, and have their some beta blockers on board at a minimum to get the blood pressure and the heart rate down to reasonable levels. Sometimes, and not uncommonly, that also requires management of the of any pain that they might have, which can also affect the blood pressure and the heart rate. So you want to get the pain managed, and that's a good start.
Yep, so you'd have an arterial line and an intravenous beta blocker.
Yeah, fairly rarely in these situations they actually come to us with an arterial line. That's a luxury, but ideally that would be the case because you want to have your blood pressure monitoring and management as tight as possible, and an arterial line certainly is a better alternative than a blood pressure cuff, particularly in the advent that it's not extremely common, but the dissection can change what the peripheral arteries are seeing with regards to blood pressure, and that's what a cuff is going to look at, as well as an arterial line, and the central pressure may be a little bit higher. So to whatever way you can access and monitor the blood pressure the best possible way for that individual patient and get the heart rate and the blood pressure down. We like to see a heart rate down around 60 to 70. We'd like to see the systolic pressure, somewhere around 100 to 110. It's not always realistic in every individual, but to transport somebody over an hour or two with a systolic pressure of 180 or 190 is just completely outdated.
Yep. And so how are you going to receive them in your hospital? Are they literally coming up to the OR? Or let's say somebody, they were missed initially, they thought there was a heart attack, the next day they've looked at it. I mean, can you wait a while? If it's 3 a.m, might you sit on these a while in your ICU?
Well, I think you really have to, it's all about the patient. You have to tailor the patient. Let me give you some examples, and various patients may fit into some of these. Patient's unstable, or we believe that there's a critical margin with regards to time. In other words, the tamponade is beginning, and the blood pressure and everything is presenting us with an acute event that's deteriorating rapidly. We just go straight to the operating room because you can just deal with everything there. There's another group of patients who are diagnosed with a type 1 dissection where the initial CT scan, because they weren't really thinking of dissection, they were doing it as a screening study, it's done as a non-gated, and you've got a motion artifact, and now they think it's a dissection, and they're convinced of it. You may take those patients and have a short visit to the intensive care unit and then decide whether or not you need to repeat the CTA or an echo would be enough, or both. It's not inappropriate to take those patients to the operating room and do echocardiography on them if there's any question, because you can move ahead if it's positive and it really wasn't a false positive through a motion artifact. In other patients that are perfectly stable, that they don't have a pericardial effusion, they have minimal or no aortic valvular insufficiency, and it's 3 o'clock in the morning, and your proper team in order to manage that patient is going to be in at 6, to wait a couple of 3 hours is not completely untenable. But if they're unstable or if there's any question, the safest place for these individuals is to be with a competent team in the operating room.
And do you like to have always imaged the descending aorta down to the femorals, or is that not important for you?
Well, you don't always get that as a luxury. Sometimes it can come on the initial study, and I wouldn't take an unstable patient to repeat a CT scan to acquire that information. I would go straight to the operating room and base everything on a physical examination.
And then finally, I suppose, a patient that's come to you and they've got an ischemic looking leg, or they've got severe abdominal pain, you wonder if a vessel's been compromised. Do you go to theatre, or do you address that first?
Well, it depends. If I don't have an adequate study and hemodynamically they're otherwise stable, I might get a CTA if I'm worried about mesenteric ischemia or a distal leg problem. Those things can be sorted out in the operating room or in a hybrid suite, but in many institutions that's probably not optimal. We like as much information as we can get, as long as it's safe for the patient.
Yep. So we're in the operating room, so it's time to start the operation. I suppose the first thing is cannulation. So first of all, I suppose for the average cardiac surgeon, where should we be routinely cannulating in a type A dissection?
Well, it depends. If I've got a contained rupture and a bad tamponade, and I think if I open the pericardium, the patient from a hemodynamic standpoint is going to collapse, then I cannulate a little differently. In the past, we've routinely cannulated from an arterial standpoint a femoral artery, but now we would probably use the right axillary artery in cases like that. If you need to go on pump before you open the chest, we'll use a right femoral vein, place something like a glide wire up to the right atrium, a burn catheter, replace that with a stiff wire, usually an Amplatz, could be a Lundquist, and then run a 24 French catheter up to, from the right femoral vein up to the level of the right atrium, confirming all that on transesophageal echocardiography. So now you've got your right axillary artery and your femoral vein, and you can go on pump and cool down before you release that contained rupture under very controlled circumstances, under a reasonable level of hypothermia.
And I know for a lot of your sort of elective work, thoracoabdominals, you use carotids or anomanetes just through your stenotomy. Do you ever do that in a dissection, or is that not as safe?
You can, but it's we use the right axillary artery purposely because once we go on circulatory arrest, it's a partial circulatory arrest because we're going to occlude the anomenate artery and perfuse the right carotid artery through the right axillary artery, and it's part of our brain protection approach.
So, and finally, I suppose on cannulation, you're wheeling the person into the OR, they absolutely crash, they've lost their blood pressure straight away. What do you think the way to proceed is before you've even started?
Oh, I think in a situation, it does happen from time to time. You know, these patients with acute dissections, they can be looking at you and seem perfectly stable 1 minute and then just literally within minutes. And what's happened in these cases, they've ruptured into their pericardium or they've reached a situation with the tamponade has been so extreme that they finally tipped over. The other thing that can happen is that they're relatively stable, and then with intubation and the induction of anesthesia, they can go down. In those cases, we believe that femoral bypass is the way to go. We have had in very few cases, but it is possible to actually do that in an awake patient and then induce anesthesia, but that would be kind of an extremely unusual situation.
So even if they arrest, you'd rather fem-fem bypass rather than open up and say put in a pipe down the LV?
Well, you know, that's that's always a possibility, but in general, that moves into malperfusion issues where we would use those techniques. The problem with a rupture, a contained rupture, is the ascending aorta is just blown out on you. And to open the chest, you can relieve the pressure, but then you've got a wide open aorta and they're exsanguinating out of that, and you just don't have much control of the situation. It's better to get them under femoral bypass and then proceed from there, we think, safely.
So let's say we have a stable patient, a 50-year-old gentleman, and you believe the dissection flap to be in the mid-ascending aorta. What should be just our safe standard operation? Are we just going to hopefully plan for a simple interposition tube graft, or how do you plan your operation, or how do you recommend someone does?
Yeah, well, that's what we hope for. If you've got a dissection in the mid-ascending, our plan is to open the chest. We used to use the right axillary artery routinely. Before that, we used the femoral artery. But now, we'll generally look at the innominate artery. And if in the distal innominate artery or the very proximal right common carotid artery, we can put a partial occluding clamp, sew an 8mm Dacron graft on, then that's part of our brain protection strategy and for antegrade cerebral perfusion. And then we'll use atrial cannulation, retrograde cardioplegia, and usually a left ventricular sump. Meanwhile, transesophageal echocardiography is helping provide us information with regards to the size of the aortic root and aortic valvular insufficiency. In an ideal situation where the root's not involved and the valve is competent, then we cool down. And that temperature that we've targeted is varied over the years. If we think it's a relatively uncomplicated situation, we cool down to about 24 to 26 degrees centigrade, on occasion even as high as 28. But in dissections, you want to be a little cooler because things never are always what you see. There always seems to be a wrench in the bucket somewhere. And so we would drop our flows down to around a liter or 1.2 liters per minute in a 70 to 80 kilogram man, occlude the innominate artery, so now all that's going into the right carotid artery, and then we would transect the aorta proximal to the innominate artery. We'd give start retrograde cardioplegia, and then as soon as we can, give some antegrade cardioplegia also, although that's variable. And so now we're looking at the open distal arch, and we would take a examination to be sure there's no tears in the arch or the very proximal descending. You can use a cardioplegia cannula, or we use most commonly a 9 French Pruitt cannula, wide off the arterial line, up into the left common carotid artery for bilateral perfusion. It's not much in the way of an obstruction or encumbrance to have that little extra catheter there. We put
and at what temperature do you take the clamp off to do that?
We're 24 to 26 degrees. Yeah. So then it's not uncommon to put just a small amount of CryoLife BioGlue, or whatever BioGlue your choice is, into the false lumen distally, and then sew a graft on, usually a Dacron graft using a common scenario would be a running 4-0 Prolene suture backed up by a series of circumferential 4-0 mattress plegited sutures, which is a relatively hemostatic anastomosis, which then allows us to then finally clamp something, which would be the graft, and reinstitute perfusion into the left subclavian and the lower extremities, et cetera, the rest of the body, and then do whatever's proximally based on the dictates of the anatomy.
Yeah, so you're doing a distal anastomosis
first. This is the simple, straightforward scenario.
Yeah, before we get complex. Yeah. So you put your distal graft on, and you've used your BioGlue and got the adventitia looking really nice and 4-0, and then you'll do the proximal anastomosis as you warm up.
Yeah, you're beginning to warm up, and then you do your proximal, pretty much of a similar suture technique. It can vary with the consistency of the tissue and whatever the individual surgeon chooses, but you want a hemostatic proximal anastomosis, and then you're getting pretty close to warm. Do your de-airing and wean, come off pump.
Yeah, so you're Mr. Joe Average surgeon, and you've taken the clamp off, and actually the tear is a retrograde type A. The tear is actually distal to the innominate. I mean, should an average surgeon be chasing tears sort of down into the arch, or should we just be concentrating on proximal protection and just put your tube graft on, get out?
Yeah, it's generally in those circumstances not the distal aorta that does the patient's in, it's the proximal aorta. So I would probably, in the average situation, recommend, just sticking with the basic plan. Because we're a referral institution and have a fairly robust endovascular stent graft program, we're just one of the places that in this setting are continuing to try to evaluate the impact of placing antegradally an endovascular stent graft in the true lumen with the open arch prior to doing the arch reconstruction to see if that has some short and long-term benefits for patients. In our own work, we've found in the short term, in patients with malperfusion, it's been quite helpful, but in the uncomplicated case, I think it's still up in the air for a lot of patients. We're just going to have to see.
And I suppose the other horrific situation for us surgeons is, you see a big hematoma and you've compromised your right coronary artery, and that, I suppose, can be quite difficult to handle. Do you have any good tips for if you think that's been compromised?
Yeah, if you think the dissection's gone down around the right coronary artery and then kind of scooted out into it, there's a variety of choices, and I think it's you have to do it just based on what you're comfortable with and what you're looking at and the size of the coronary artery, et cetera. So a couple of things that I've done in the past is I've taken a small red rubber catheter and placed it in the right coronary artery and then obliterated the false lumen, sometimes with CryoLife BioGlue, but not uncommonly in the non-coronary sinus, we'll put a little piece of Teflon felt in there as part of that portion of the reconstruction. So now I've got the false lumen obliterated, but I've still got this little red rubber catheter in the right coronary artery, and then you take that out after the BioGlue is set up, and if it all looks okay, then that coronary is probably pretty well protected. If the right coronary artery is completely sheared off and it's not acceptable, then in most cases you just simply have to take a little piece of vein and do a bypass.
Yeah, and I suppose finally, if your average surgeon comes in, it's a 32-year-old patient, they've got a big bulbous root, and they're going, oh, this is a Marfan's that's been missed. I mean, is it still acceptable for them just to do a tube graft, get out and fight another day, or is that not really adequate in the modern surgery?
Yes and no. Ideally not, yeah, but I think in this entire discussion, the ultimate goal is to have a live patient who can recover from the procedure out of the operating room. And if that means not doing the maximum desirable amount of reconstruction at the time of surgery, so be it. That can be addressed at a later time. But I think with in our situation, we would, if we are addressing an individual that has a connective tissue disorder like Marfan syndrome or any other reason has a root aneurysm, we're going to replace it at the time of the initial operation.
Yeah. So we've done a successful aortic dissection repair. The patient's got out brilliantly. How should people be following these people up? Because they do have a high incidence of complications.
Yeah, good question. You know, we keep these patients in the intensive care unit for at least 48 hours post-operatively. We've got to monitor the blood pressure and their hemodynamics, their peripheral circulation, their urinary output, and the whole thing. And it's a very worthwhile investment of time and effort. A couple things on this subject. It's important, I think. One, in my mind, I think of taking a type 1 aortic dissection or a type A aortic dissection. If you replace the proximal aorta, you've now converted it from an acute type 1 to an acute type 3 or an acute A to an acute B. So now you've got the distal aorta you've got to manage, and then use the protocols you normally would use for an acute type B aortic dissection, which is blood pressure management primarily. In the routine case, patient does well, as you just described. We try to get a CTA prior to discharge. Part of that is to get a baseline for comparing additional studies for surveillance down the line. That's provided, of course, that the kidney function's reasonable. Occasionally, you will identify some things on those discharge CTAs that you might not have identified otherwise, and it's good to know. I can't. What comes to mind, retroesophageal right subclavian artery that was met, whatever. And then our follow-up program involves obviously blood pressure management, but then of course the sequence of additional CT scans, if that's your choice to follow the patient and when to do them. The sequence or the frequency of additional studies depends upon a lot of things. In the usual situation, after discharge, we'll get another CT scan at 6 weeks to 3 months, and then in 6 months, and then yearly, provided it's stable. If the aorta is expanding or there are any issues, then of course you accelerate that and shorten the time frames. A couple of things to keep in mind. It's actually perfectly acceptable to get MRI scans. They're not as widely available, although by and large they're available. They're just not as available as CT scans. They're a little more expensive. They take a little longer to do. Once the aorta is stable and you're just following the diameter, in other words, you've got a patient you're following on a chronic long-term basis who is clinically stable. They've not had any changes, symptoms and that sort of thing develop over time, and all you're really looking at is the single metric which is most importantly associated with a course which is going to require intervention, and that's the outside diameter of the aorta. Many of these long-term studies can be done without contrast. They get less radiation, they don't get the contrast. And of course, then if it's expanded, if it was 3.5 and now it's 4.5, you may want to go back and do contrast. But if you're just over the years getting multiple studies using a CT scan, the use of contrast in every single situation is not always necessary.
Great. Well, that's an absolutely fascinating insight into dissection. I'm almost looking forward to my next one after that. So thank you very much for that insight. So from myself, Joel Dunning, and everybody at CTSNet, can I say thank you very much?
You're very welcome, Joel. It's a pleasure to be here, and congratulations on all the work y'all are doing. And the education opportunity for CTS is extremely important to our specialty.
Great. Thank you very much.
You bet.
Yeah.